Okay, welcome everybody. Welcome to another in our series of webinars, which obviously you're gathering 360 do as a kind of service to our patients and the community beyond. Interestingly for Lisa and I, we've been invited to speak in America at the end of November on the subject of ADHD and physical health. And this was requested as a UK session. So in a lot of ways, this is a kind of informal rehearsal for a very formal presentation at a conference that's coming up soon. And in prepping for tonight, Lisa and I have talked about, well, what should we pick as the subjects? And obviously we'll start with kind of our agenda base, won't we, Lisa? And then we'll be watching the Q&A and the chat, and we'll pick stuff out of there as is our usual routine. So the two chunky things that we thought we'd talk about as a starting premise, if you will, is we'll introduce ourselves, and then we'll talk about ADHD in a relationship with food and disordered eating, the words Lisa used earlier. And then we'll also talk about hypertension, BP, and I'm pretty certain we'll get into women and the menstrual cycle and women in the menopause if we can get there. Other subjects that could pop up, if you take the disordered eating, that leads very much into a diabetes conversation, and we're firmly of a mind that actually diabetes can be looked at as a co-occurring condition for ADHD, especially pre-diabetes, and what can we do about that? And those are the kind of physical health crossover to ADHD, if you want to call it mental health or mental ill health, if you're so inclined, that we're hoping to pick up. So Lisa, do you want to introduce yourself, and then I'll do the same, and then we'll throw it open to start.
So my name's Lisa Mangle, and I'm a clinical director at ADHD 360. I've worked in ADHD now for 20 years. Some of that in the NHS, some of that in the pharmaceutical industry, and the medical team, teaching a lot of doctors, nurses, in-house people about what ADHD is, what it isn't, how the pharmacology of the medicines work. And then the last 4 years, Phil and I and a few others set up ADHD 360, and it's just blossomed. And I think what working for ourselves has allowed us to do is look at these conditions that actually a lot of services would avoid and not treat, and actually think holistically about the patient. So I spend a lot of my days assessing patients and supporting the team and thinking how we can manage patients and optimise the treatment. So yeah, that's me. What about you, Phil?
Nowhere near as exciting. My name's Phil Anderton. I'm often referred to as the village idiot from Heapham in Lincolnshire. I'm the managing director of 360. And together with Lisa and Jen Lewis-Neal, we set this up nearly 4 years ago now to try and bring excellence into ADHD clinical work. I do not look like Gary Barlow, just looking at the chat. And we set out to treat about 20 or 30 patients a month. Such is the demand that we're now treating 700 new patients every month as a service. We're probably the UK's biggest, if not Europe's biggest service that focuses on ADHD. We're really, really proud of what we do, and we know we don't get everything right, but we know we strive to our very best. And webinars like this on a Wednesday evening are a key part of what we're trying to do in terms of that overall understanding within the ADHD community of understanding ADHD a lot more. So enough waffle from me. Let's crack on. We've got a couple of people asking for Lisa for EDS to be mentioned as well, and we'll have a look at EDS when we crack on. Let's just throw it straight into Lisa. Let's throw it straight into disordered eating and what that can mean for ADHD. Now, if you were to Lisa, if you were to sort of start talking about disordered eating, what would be the context of why there's a correlation and why there's a link between disordered eating and ADHD.
So my knowledge of disordered eating goes way back to when I worked in paediatrics, and I did a bit of an audit of 100 consecutive patients, and I went right back to the beginning of their referral and literally went through the whole set of notes and proper did a deep dive into the data. And I shocked myself at how many of my paediatric patients were obese when they came to my clinic. And obviously, when you treat them with stimulants, the first thing you think of, oh, it's a side effect of treatment, and that's why they're losing weight. But over time, I realised that actually they'd been binge eating when they were untreated, and the weight loss was linked to the lack of binge eating. And you know, I talk a lot, probably on a daily basis, about disordered eating. And when you've got untreated ADHD and you go for your assessment, you turn up with an expectation of I don't know what, and I start talking about, tell me about your busy brain, which is not one of the core features of ADHD. But when you've got untreated ADHD, you've got this brain that just doesn't shut up. And it's like a laptop with multiple tabs open. So you've just not got this seminar or webinar that you're focusing on. You've got what's for tea, what can I have tomorrow, have the kids gone to bed, who's brushed the teeth, who hasn't. You've got all this going on in your head. And one of them is likely to be food. And if you've got that tab open that's food, and you've got untreated ADHD and you're impulsive, then you go and make yourself a cup of tea and there's a packet of biscuits there that's not quite open. And by the time the kettle's boiled, you've eaten them all because you've got this food tab open and you've got impulsivity that's not been treated. So you can see how there's a massive link between ADHD and disordered eating. And then it can go a step further then, and you can end up feeling guilty about the binge eating, and then you start to purge. So then you get into that realms of have I got bulimia? Well, actually, no, you've got this tab open in your brain, you've got impulsivity, you've eaten, you didn't want to eat, you want to have proper food, and then you feel guilty. So, you know, the aim of the treatment for your ADHD is to shut that busy brain down, shut that tab down so that it's harder to find, and stop the impulsivity. And that's the aim of treatment for your ADHD and your disordered eating. And it comes, I mean, I guess, Phil, we spoke earlier about there's more to it than that, because with untreated ADHD, you can't prep, you can't plan. I spoke to a patient only today, and he spends a fortune on Uber Eats because he goes to the fridge at 8 o'clock at night when he realises he's hungry and there's nothing for him to eat because he doesn't have the ability to go food shopping or have a regular pattern of food shopping or know when he's running out of food. So he's got into a pattern of not eating good food and not eating properly and not eating regular meals. So I think it's all intertwined with ADHD, and it's a fascinating area that I wouldn't shy away from in terms of treatment.
It's interesting as you're talking, Ellie. So I'm watching the chat, and there's a lot of people here going, wow, I've never seen it that way. Wow, that's me. I'm on the 3rd day of meds and already I'm eating less. I've been on meds for 2 weeks and I've lost a lot of weight. And it's not, there is an element of appetite suppressants in the medication. Of course there is, we know that. That's a known side effect. What there also is this this planning of diet a lot more and not being as impulsive, and therefore we can get a change. And one of the coaching things we talk about is if we accept that there's an appetite suppressant element of the medication, when that's waning off, when you get into the tail of your medication and your hunger's going to come, then you're going to have something decent available, because if not, you're going to go to crap food, and that's where your Uber Eats can still kick back in. And this is what somebody commented there: first month on meds and I've saved money because I used to spend £300 on takeaway a month. And these are the unseen benefits of proper treatment for ADHD, and these are set of benefits that just don't get recognised in terms of what we're looking at with holistic health. There's a couple of questions coming about children who are really fussy eaters in childhood and eat very little. And I think for me, Lisa, I'm going to bring you in a second, but for me, that smacks of less ADHD and more in the autistic end of a continuum. And I've been in Manchester all day today, and I drew a diagram, and the people I was talking with, it really resonated with them when I said, if we talk about a spectrum for autism, but we don't talk about a spectrum for ADHD, we just talk about ADHD. And if we actually drew a line and had autism one end and ADHD the other, and you could have a slider that you moved up and down that line, you've got to accept that you'll very rarely, if ever, get all the way down to one end so that it's all autism, or all the way down to the other end so it's all ADHD. What you're going to have is that slider being positioned. And depending on where that slider ends up, could determine which treatment pathway you go on. But it doesn't recognise that there's still going to be something here or something here that needs to be addressed. And one of the failings, I think, of UK health is that we look for what we're looking for and we don't treat anything else. And, you know, the start of our autism service at the very back end of this month is going to start to actually look at this as a whole line as opposed to where do we put the slider. And I think it starts to get so exciting. So I would suggest for the child that's a really fussy eater, we've got to find the things that the child wants to eat at first and then readdress their relationship with food and start to build in the confidence of eating and start to build a positive relationship and build that up. And I think that's, we often say, don't we, Lisa, if your child isn't hungry, don't force feed them. If your child is hungry, let them have food, especially at the start of a medication campaign as treatment for ADHD. I know in relation to our son, we put something in the fridge every night for him. He's on ADHD medication now, and we put food in the fridge for him every night so that when he comes down, two things happen. One is he finds good quality food that he can eat, and it's not going to be affecting his diet too much unhealthily. And the second is he's not waking me up, getting knives and forks out and banging plates around and what have you. And I nearly throttled him when he did that at 1 o'clock in the morning last month. But adjusting our needs to meet his was a really difficult thing to get our heads around, even though we talk about it. It's actually really difficult. Why do we have to sit down as a family at 5 o'clock in the evening and have a meal together when one of your family, maybe two, whatever, is neurodiverse and actually needs to eat at 8 o'clock at night? It doesn't bloody matter. Let them eat at 8 o'clock. And if you provide healthy food at 8 o'clock, which is still attractive to that child or to that adult, then you build a better relationship with food, don't you?
There's a question coming in about, can it be disordered drinking? And that's a really good question. And so when we do our risk assessment, when we're assessing our new patients, one of the questions is, so tell me about your relationship with alcohol. Because when Phil and I worked, well, certainly when I worked in the pharmaceutical industry, I used to visit a lot of substance misuse services, and the staff used to say, you know, half of our patients are very different to the other half. You know, they can't queue, they can't turn up on time, they can't engage in the programs that we offer. And they were screaming ADHD patients. And the thing with alcohol is that when you drink alcohol, your brain slows down after a couple of drinks. So all this noise just shuts up a bit, so that you can actually relax and have a conversation. Because if you can't slow your brain down, it's hard to have that conversation if there's a group of you. So in actual fact, a lot of people with ADHD, without even realising it, do drink alcohol to slow the brain down. But then they often don't stop at a couple, and then it can become destructive. So that is one of the questions that we ask all our patients, and it's really common that there's been a history of alcohol overuse in order to self-medicate for their untreated ADHD.
There's a comment on the chat here. This just made me smile, if not laugh out loud. I'm sat here waiting for my takeaway, drinking an alcoholic drink. I'm like, oh, hello. And and what we can do as well is we start to accept habit as being what we need. And one of the things as we start to readdress the relationship with food is to try and break habits that aren't overly healthy. So there might be, after a day of tea and coffee at work or whatever it is, soft drinks, you just get a little bit bored with what's on offer. And we recommend go for that. If you want something different at this time of day when you come home. Are you craving alcohol? Are you craving a different taste, a different flavour, and a different sensation? If so, have an alcohol-free beer or an alcohol-free gin and tonic or something. And actually don't crave the alcohol, crave that different sensation. And that makes a big difference. And I think, it's all about addressing that relationship with food. And I think our patient guide, which is due out at the end of the month as well, starts to address this as a key issue. And it'll be in all bookstores available. It'll be free on a PDF. But we've got to actually start to think about the correlation between poor physical health through diet and why ADHD is either a driver or a participant in that process. Let's just talk about diabetes for a second, Lisa, because that's an easy segue from where we are. The medical fact about diabetes is it's incredibly on the rise in modern society. We've prepped some stats for the American conference at the end of the month, and it's horrendous what the projection is for diabetes, and yet nobody's making the correlation to ADHD and disordered eating. So make that link, Lisa.
So when I worked for the pharmaceutical industry, one of my tasks was to look at binge eating in the UK, because in the US, one of the medicines for ADHD is licensed for binge eating. So the plan was to come and bring the product over here for binge eating. So I had a great geeky few months looking at all the eating disorder conferences. And my job would have been to go to all the diabetes clinics and bariatric surgery clinics to look for patients with ADHD, which is dead easy. You can just do an ASRS screen. It takes you about 30 seconds and save you a lot of heartache and a lot of money probably and surgery. And in terms of type 2 diabetes, when you can't plan and you can't organise and you're impulsive, then you've probably not got much of a chance of sticking to your type 2 diabetes diet, because it's really difficult and it takes a lot of commitment. And I've had patients who their type 2 diabetes has been off the chart when they came for their assessment, and they were just carrying on as if nothing else was happening. And what was going to happen there is the life expectancy would have been severely impacted. And with the treatment of their ADHD, not only have they stopped binge eating, but they can plan and they can organise and they can cook good food and they can cut the carbs out and make good choices. And it's a game changer, really. And it's giving them the opportunity to live that life that they deserved in the first place. And, yes, we're here to look at ADHD, but actually you've got to look at the whole patient. And if I can help someone's diabetes because I've sorted their ADHD out, then that's what we're going to do. So we've got many patients. And again, a lot of people wouldn't treat someone with diabetes with a treatment that might impact on their appetite. But we're quite creative here at ADHD 360. So we will look at immediate release medications first, for example, so that you can allow the person with diabetes to have regular meals but still be treated for their ADHD in between times. And if that's successful and they've led you to believe that the diabetes is under control, then you can go to extended release medications. But it will absolutely change the trajectory of someone's diabetes pathway if you treat your ADHD.
Yeah, there's a comment in here, and I'm going to bring some real world evidence into this. There's a comment here about the link between ADHD and autism, and hopefully that diagram of that bar with the slider starts to answer that question. And there's comments here about my child only wants to eat sugary drinks, or my child, or whatever. You've just got to recognise that although unhelpfully at times we might have a diagnosis of ADHD, you are going to have a sprinkling of autistic tendencies in there, because it's all prefrontal cortex, it's all the main part of what's going on. So we can't afford to exclude what else we're seeing. And especially we talk about clearing the fog. if someone's mainly ADHD, we can treat that and suppress the impairment through treatments. You're going to see the other things that are there a lot clearer, and one of those may be sensation, and that relationship with sensations and food. So you've got to be prepared to actually work with that as an autistic coaching element of managing that, and looking for other foods that are sensations are attractive to that child, and readdress that balance. The real world piece is that in January I was diagnosed with type 2 diabetes. I'm not ADHD, and I was left with no choice. Somebody here said they were severely ill with type 2 diabetes. I was given no choice but to change my lifestyle. Not having the impairment level of somebody with ADHD, changing my lifestyle was relatively straightforward. And Lisa and my wife and my team have lived through that change with me. And, you know, day one, week one, I've got to be honest, I was pretty bloody miserable about it. But I changed on the day and never went back, and never have gone back. And I've lost 4 stone in weight, and have reversed my diabetes. And the point that we're making is that you're never going to do that with untreated ADHD. You're never going to have that structure, that regimen. You're never going to have that drive to do that unless you become someone that's so hyper-focused, and that's going to be rare with diet. So you treat the ADHD, you can then become the person that completely changes their diet, plans their meals, as opposed to grabbing a sandwich or grabbing a bag of crisps or feeding themselves on chocolate. And I was that man. And I can't imagine how difficult it would have been for me to reverse that if I wasn't organised and a planner and those kind of things. So, you know, there is a lot of good news out there. Somebody's just they've switched their fizzy drinks, because we talked about alcohol, we haven't talked about soft drinks. They've switched their fizzy drinks to caffeine free. Hallelujah. Yeah, get off caffeine. It just becomes another stimulant, completely cocks up the medical regime, cocks up the medicine. So we drink caffeine-free Coca-Cola in the family. We drink Diet 7-Up. We drink a lot of water, teas and coffees, and steer clear of full-fat Coke, as I call it. There's other drinks now that are less tasting of aspartame and what have you. If you go and shop around, and I would just implore anybody, stay away from caffeine drinks, stay away from sugary drinks, and don't make that a habit. Break the habit.
Can we segue into blood pressure? Because sorry, go on.
Yeah, well, I was going to say hydration and blood pressure is a really, really good segue. If we're going to hunt the segue, that's a good one, because
someone's mentioned the disordered eating. So she wants to know how to manage the disordered eating without taking ADHD meds, because she's got high blood pressure and her GP's advised her not to take stimulants. So, I mean, obviously, I don't know more information about that, as in, have you taken stimulants and your blood pressure's gone up? But we do have a fair bit of data around patients who present with high blood pressure, and we've treated them. I mean, we've done it in a very safe, controlled way by monitoring the blood pressure on a daily basis for an extended period of time before we've decided to go down the medication route, but then started medication and continued to monitor the blood pressure on a very regular basis. And we've mapped actually that a lot of patients, the blood pressure will gradually over time decrease to certainly the patients we're looking at to a normal level, because actually the blood pressure was being caused by the poor diet, the stress, the anxiety, the adrenaline that they have to use to actually get something done is so disruptive to the blood pressure and the pulse. And
shall I share that slide?
Yeah, if you've got it to hand, Phil, that'd be great. So we've got a slide of a patient who presented as a 27-year-old, and as you can see, his blood pressure was 180/120. He'd never had his blood pressure done before in his life, and I got the shock of my life when I did his blood pressure and thought, what the heck's going on? So obviously we looked at other potential medical reasons for why he might be so hypertensive, but then But then we did his blood pressure regularly and then started treatment, started low, titrated slowly. But as you can see, by the time we optimised his treatment, his observations were normal. He'd also lost a significant amount of weight. He was eating healthily, more active, just having a really good life. And yet at 27, with that blood pressure, he probably weren't going to live beyond 40, because he probably wouldn't have had his blood pressure done before the age of 40. So some disaster would have happened. And so, you know, we've got to look at, you know, what is your blood pressure doing? Why is it up? Obviously do the things that need to be done, you know, check your bloods out, any renal tests that might need doing. But if everything comes back okay, then I think starting some medication and safely and regularly monitoring that blood pressure is the way to go, not to go, you can't have treatment because you've got a bit of a high blood pressure.
And I think we've got to point out there, Lisa, that what we did was we took that chap's, he had no idea he was hypertensive. We took his blood pressure every single day, or he took his blood pressure and sent it to us every single day. And we were able to monitor the safety of that. There's another patient on here saying, been on a stimulant medication for about 5 or 6 days and the BP's gone up. Well, okay, let's monitor that. And if you're one of our patients, you'll have a BP machine. Start sending your BP machine readings, taking them and putting them onto the portal. But don't become fixated with it. Don't become so anxious that the anxiety of taking your blood pressure drives your blood pressure up, which becomes a self-licking lollipop and what have you. But just keep an eye on it. And if when you come to your review, your follow-up rather, when you come to your follow-up, make sure you mention it. And if you are worried or you've got any concerns, you just need to pick up the phone and drop us an email if you're one of our patients. And medication for ADHD will reduce anxiety, and if we reduce anxiety, we have a correlation to BP. Somebody's mentioned here that they keep not drinking enough and not hydrated, and that has effect on your blood pressure. It massively does. And whilst we're saying and advocating don't go for caffeinated drinks, we've got to be advocating 2 to 3 litres of liquid a day, preferably water-based, not something that's gonna make the situation worse, and really keep your body hydrated. And if you don't keep your body hydrated, everything's going to start to go. You know, we get headaches, lack of concentration, lack of focus, and all of those things sound like ADHD symptoms, but actually they could be the symptoms of dehydration. So even if you don't think it, have a bottle with markers on it that you have to drink within the hour, or you have to drink regularly, and make sure you are doing that.
I always say that if your mouth's dry, then so is your brain. And I want your brain to be like a grape, not a raisin. And so that brain's not going to function properly if your mouth is dry. The other thing to say about treatment, which some clinicians may not have considered, is Inchinib. So Inchinib, also known as guanfacine, is also a treatment for blood pressure. And so it's only licensed in children in the UK, but it is licensed in adults in Japan. So there is the data and the evidence to say that it's safe in that population. And obviously a side effect of Inchinib is that it lowers your blood pressure and it helps with sleep. So although it's not licensed in adults, it doesn't mean it can't be prescribed. So it's something to consider if your blood pressure is up on stimulant treatment, then I think Inchinib is a way to go. And it's a 24-hour product, so it's got some nice benefits as well.
Yeah, there's a request here, just to go back to something for a second. The correlation between anxiety and ADHD. Let me just round that one out and we'll move on to another subject. Perhaps we'll move on to EDS, Lisa, because there's been a couple of requests for that. People who've attended our webinars before will be tired of me talking about being situationally cheesed off, and that whole it's not called situationally cheesed off, but I don't know who's listening. Situationally peed off. with life. And we can track that back to the age of 6, where you start to not have friends and friendships, or they become more difficult to sustain. You're the child that's not invited to sleepovers and parties. You're kept back in school to get your work done. The work is harder for you than it is for the lad or lass sat next to you, and so on and so on and so on. And then when you're starting to fail, and then someone says, we're going to do this again, it's this week's episode of chemistry, and you think, oh, flipping, I flunked that last week because I couldn't follow what was going on with the molecular structure of whatever. You start to get anxious about what's coming back round, and that starts to build into a life pattern of anxiety. You go into adulthood, relationships, holding down a job, budgeting, driving a car, blah, 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 all the things. If you're anxious about all those things, you are going to have anxiety, but you can track it back to being 6 and sat in the classroom and really struggling to get on top of things. Now, if we suddenly give you the skills, the competence through treatment and medication and coaching and all those other things, if we give you the competence to be able to be better at those things, you will start to see a pattern of life where, oh, actually, I can do that. I can walk in, sit down and have a conversation with people at work without blurting out, without spoiling it, without telling them the punchline for the joke when someone's only halfway through it. I can submit a piece of work in time without being frightened to submit it because it's going to be rubbish because I left it too late. And as you start to see those changes, and people are listing those changes in the chat, you start to become less anxious. And if your BP is driven by your anxiety, then it's a gift to be able to reduce your anxiety and therefore watch your BP come down at the same time. Don't get us wrong, and please don't misunderstand us. There will be people with ADHD who've got hardened arteries. They've got natural causes of high blood pressure. I've got hypertension. It's not based on anxiety, although running this firm it might be. But it's just a medical fact for me. It's genetic. So you can't cure everything with what we're talking about. We don't want to overstate it. But we know and we work with disordered eating, poor relationship with food, anxiety, change all of those things, and we start to get a healthier body and a healthier lifestyle, which leads then to a healthier mind, which leads to better symptom control for ADHD. Bang, wallop. Lisa, EDS and ADHD. What I'm going to ask you to do is, first of all, get the words right for EDS, because I never can, and then talk about what you see in clinic, but then follow that with why there is an emerging theory about what might be going on.
Yeah. So EDS stands for Ehlers-Danlos syndrome, and there's many types of EDS, but the one that's linked with ADHD is the hypermobile type of EDS. And EDS is impacted, it's a genetic condition, and it impacts the collagen. So collagen is the stuff that holds your body together, the glue that holds your body together. And so when I'm preparing for my patients, so I prep for my patients at least a week before, and I read all the notes, and I read what meds they're on and what medical problems they've got. And I can spot EDS a mile off by the additional conditions that they've got, the medication that they might be on. And so EDS is a rare disease, so it's 1 in 5,000. And so we should have potentially 1 or 2 patients at ADHD 360. I suspect we've got more than 50, at least, that I know of. So the other clinicians will also have patients with EDS. But most of my patients are not picked up beforehand. They don't know they've got EDS. They know they've got this range of symptoms that doesn't seem to be connected, that they keep going to the GP with, and the GP keeps giving them something or sending them somewhere or sending them away. And so they will often come with symptoms of gastric reflux, with chronic pain in the joints and the muscles. They'll have migraine, they'll have irritable bowel, constipation, you name it. It's all encompassing. Fibromyalgia, POTS, postural orthostatic tachycardia syndrome. They often struggle with sleep. And there's a definite link with ADHD. So a huge proportion of my patients have it compared to the general population. Now, the thing to think about with ADHD is that with EDS, your valves in your heart are connective tissue. So your valves in your heart can be too floppy. So they instead of opening and closing as your heart beats, they open and then decide whether they're going to close again. So it's important, if we think you might have EDS as well as ADHD, and we're going to potentially start some stimulant medication, that we actually investigate the EDS and get your heart checked out. So it wouldn't stop me treating someone with EDS, but I'd certainly want to get them checked out. And, you know, I think most of the patients that I've picked up with EDS have appreciated the fact that this weird and wonderful set of symptoms has been recognised. And so I often, when I write back with the diagnosis of ADHD, that I mention that I think this patient may also have, and I list the reasons why, and please refer on to your local EDS service because it needs checking out. So a lot of people are talking about other symptoms of EDS, and so the gluten intolerance, joint pain, muscle pain, varicose veins in your legs, they're all symptoms of EDS. As I mentioned, your veins are connective tissue, so they expand more than most.
Let me share a slide, Lisa, because it's all well and good talking about the correlation, and I'm not putting us down. What I'm saying is, a lot of people can talk about, scientists talk about the correlation, but what the hell can we do about it? And that becomes a question. There's a lot of people on here, just expanding your theory of there's a lot of correlation between ADHD and EDS, which I know that you're rapidly becoming an expert on. What can we do about it? And here we go. This is some work that we've pulled out from other clinical work that is out there to look at. So the use of compression stockings, they're really sexy, aren't they? But compression stockings are to keep blood supply and keep control a little bit. Increased hydration and salt, bit of a no-brainer there. We've talked about hydration. And calf pumping when you're feeling dizzy or lightheaded, that's all about the blood supply and the regulation of blood supply, which is a key to EDS, and that gets overlooked. Imagine having untreated ADHD when you've got to remember this regime for your EDS. You're much better off if you've got your treated ADHD, and therefore you can remember the regime. And, you know, Lisa's job and the job of all of our clinicians, and we ran a big CPD session a few months ago on the correlation between ADHD and EDS, and had one of our team who has both take part in that session. And there were people in tears when they actually started to see that link between the two conditions and the effect it can have. And the job of the physician is to consider what treatment's going to be effective that can affect positively the physical health as well as the mental health of the patients, and indeed very carefully make a choice about medicine that is not going to make it worse. And therefore we have to make sure that we're choosing medicines in relation to the hypertensive and those kind of things. But interestingly, be cautious with ADHD medications that can cause hypotension. So if we've got a patient with EDS, or we suspect EDS, and we talk and we ask questions about joint mobility and those symptoms that we just talked about. If we then put that patient on Inchiniv, which is a medicine that we know can reduce blood pressure, then we could be making the EDS worse, and that's something a good physician should be looking at. And I go back to my diagram about, if I can, Lisa, about ADHD and autism and this spectrum, this long line with the slider. I was saying to this group in Manchester today, the label ADHD and the label autism, they're not there for the patient. They're there for us to understand what to do. They're of no bloody help, because half the time they're a hindrance, because we put things in a box and therefore we close the lid on that box and that's what we're dealing with. What we've got to do is blow that apart and say, right, this patient is suffering from EDS, probably got ADHD with a sprinkling of autism. They're overweight. They need to not be pre-diabetic. It could be a woman who's struggling with her menstrual cycle, as I said, when we come in there. And what we've got to do is we've got to come up with a treatment regime that tackles all of that not just take Ritalin, 5 milligrams every 4 hours, sod off, see you later. We've actually got to get more scientific and more holistic with what we do. And I get really energized by the fact that unless we're doing all of that, we're not actually doing our job. And I ran a session slightly off piece, but I want to make the point with people, and make the point with patients. We talk about Black people being diverse. We talk about disabled people being diverse. We talk about gay people being diverse. We talk about neurodivergent people being diverse. What if you're a Black lesbian in a wheelchair with ADHD? How the hell does our labeling accommodate that? And I use that as an example quite a lot. We tend to look for a single label. Let's stop doing that. Let's start thinking about what is it that's affected this person's life, and actually start to improve the quality of life across all of the things that we can help with. And that's really what should motivate us. And I think as a patient, you've got to start motivating yourself a little bit to look at, I could be the in a wheelchair Black lesbian who's blah, blah, blah. And if I am, don't choose a single label, just choose your name and say, this is me. Now, how can I get help about it? And change the way, the construct of how we look at medicine. Now, I offered you a segue there, Lisa, of women in the menstrual cycle. And I know this is a biggie that we talk about a lot, but we often get new people coming onto the webinars, and those that have heard us talk about this before, I generally get the feeling, I'm quite happy to hear us talk about it again. We've got an awful lot of real world evidence now of what we can do for a woman and her menstrual cycle. Talk us through it.
So we have a group of women who will say that certain weeks of their month, their ADHD symptoms seem worse. And so we ask that question when we're assessing the patient. And so what we do as a company is that we optimize someone's treatment. And what do we mean by that? Well, we want their treatment to be as good as I can possibly get it. I'm not happy, and neither of my team, we're not happy with a little bit of an improvement. We want to really optimize the patient and get them as on point as we can possibly get them, whatever that looks like. And so that's our aim as we're treating that patient, get them to the right medicine at the right dose as quickly and safely as possible, and get them to shared care. Now, those patients who seem to have a week in the month where their ADHD is more tricky, when I've optimized them, I will say to them, look, is your whole month okay? Or is there still a week that's still tricky? And those ladies that say, yep, there's still a week or 5 days where it seems like the medicine's not working, well, that's not good enough for us, because if we don't sort out that lady's whole month, then a quarter of their life is not on point, and that's not good enough. So what we do at that point is we increase the dose slightly in that week that's tricky. So they might be on, 54 milligrams of Concerta most of the month, but that week they need 72 milligrams. And so we do that and then review and do a follow-up and see how things are going. And only when we've got the whole month on point do we then go for shared care. Now, interestingly, only this week we've had contact from a GP whom a lady's moved. Well, anyway, it's a long story, but basically she's not under Lincolnshire anymore, she's under Leicester, and they're not accepting that this lady's on a slightly higher dose 1 week of the month because there's no data. Well, there's not a lot of data, but there is some data, and there's certainly people like Phil and I talking about it, and people in Canada are talking about it. We're going to the US in November to talk about it, and there's no studies because nobody's prepared to fund a study into this problem. But as clinicians, we know it's real. We're assessing a lot of ladies every single month, and a good proportion of them have this problem. So we will be arguing the point with this specific CCG, because we know it's real, and if a lady tells me that a week of the month is is more difficult than the rest, then I believe them, because why would they tell me that if it wasn't true? And optimizing that treatment makes a significant difference to their lives, to the lives of the families, and to the wider community. So we're not going to stop going on about this, Phil, until something changes.
No, absolutely not. And it's a really important issue, and you'll read in the media and other things that women are behind the curve with their assessment and diagnosis of ADHD, and you'll read that time and time again. What you're not reading is who's doing anything about it, and that's the more important argument now: is what the hell are you doing about it? Don't just bang on about it. Get off your backside and do something. Proudly, at least 50% of our patients are female, as opposed to what's quoted as national statistics and what have you. And that's because we don't have the barriers to entry to service that the NHS put up. If you want an assessment, you can have one. End of story. And if you've not got ADHD, we won't charge you that much for it. We'll just charge you for a bit of our time. And because I think you deserve, females, and I'm talking to say you, because the majority of this audience are doing, deserve that hearing, deserve that opportunity to have your health looked at. And not pushed away because you don't fit the naughty boy syndrome. And women and menstruation. I've said this before and I'll say it again. Here am I as a middle-aged man, perhaps not even beyond middle age now, senior years, mature man, perhaps not acting nobly, maturely, discussing openly a woman's period and her menstrual cycle. There's no glib humour. There's no defensive one-liners to make this more comfortable for me. This is a real bloody subject that men need to stand up for women for, and need to bring about change. And Lisa and I are very, very passionate about this. A woman losing 1 week of 4, a quarter of her year, a quarter of her life, because she's having a period is not good enough, and something needs to change. So a lot of the ladies have commented about the pill that they're on being changed and what have you. Honestly, get your doctor to talk to us, get your GP to do something that's highly unusual, and that's write to us and say, how can we work together on this? What can we do for the patients to bring out a better set of outcomes? Because we know that we can do this, and we know that we're prepared to work with any clinical team that wants to do that. And as our kind of brand awareness, if you will, grows on this subject, as people get to recognise that we're becoming experts in this, we hope to do more. I can see that Kristen's very kindly just put up, someone who said, have you met GPs? Well, yeah, I have, and I've argued with many, but excitingly, we now employ some as clinicians, and they're amazing. Yeah. And we're going to use those GPs as agents of change into primary care. Kristen's very kindly just put up the link for our paper on ADHD and the menstrual cycle. It's not an academic paper. I can write academic papers, they're boring, they're dull, and nobody with ADHD is going to bloody read them. So this is written for you. It's written to be of interest. And what I would say to you is, take it to your GP, stick it under their nose and say, there's a starting point for you. If you don't, and one patient said, my GP's openly admitted that he doesn't understand the correlation between ADHD and the menstrual cycle. Well, stick that up his nose or stick it somewhere else, but make sure he reads it and start to educate your GP. And let's be honest and let's be frank, we all own some of that responsibility. We can't just sit back and be passive about it. So the paper's written for you to be able to learn yourself and take it. And they're free, just download it, crack on. We invest heavily in making them graphically and colour and attractive to an ADHD audience. We invest in that, and we never charge anybody a penny for it, because this is part of the greater good. And we want to make that difference. Now, somebody's moved the conversation on here, Lisa, and that's into the menopause and perimenopause and the post-menopause. And that's the next maturity of the debate. And Rebecca Whelan, one of our senior clinicians at the moment, is studying this heavily, because that's the next stage of learning for us. But what we do know is, as the hormone levels fluctuate and change in that cycle for a woman from the age of mid to late 40s, normally onwards, you're going to get that similar kind of response that you get for the 1 week out of 4, but it's not consistent, and it's up and down, and you're hot 1 minute, cold the next, and you're happy 1 minute and you're sad the next. And what we've got to try and do is work with that and as a complete package for the lady patients. And we're working with that, and we're actually rather excitingly, we're on a television program in the next couple of weeks, a daytime telly program discussing this and discussing women's issues with ADHD. And we'll once that's allowed to be announced, we'll announce that through the channels that Kristen pushes out on social media. But I think that's an opportunity to raise these issues of menopause, menstruation, and what have you. But let's be clear that there is something we can do and will do to make life better for women with this. And at the risk of saying something contentious, I think by doing so, we make things better for blokes as well, because it becomes easier for the whole household. And that's not me being trite and putting things down, but if you've got a patient who is suffering in the house, everybody will suffer to some degree. Therefore, we can have a completely holistic perspective. Kevin, I get you. A completely holistic perspective on this, and start to champion things. And I get excited about that. And, you know, I think what we've looked at here, Lisa, if I canter back, we've looked at, wow, 55 minutes have gone. We've looked at disordered eating, the relationship with food, what we can do about that. And I've mentioned it before, and I mention it again. We have a new patient guide coming out very, very soon. It's in the final proofreading now. Quite excited about this, which helps you with all of that. We've talked about diabetes and the risk of diabetes and how pre-diabetics can be helped, and indeed diabetics and the challenges of that. We've talked about EDS and hypermobility, and how we can see that correlation. There's some simple things that you can do, and what your clinician needs to be careful of in terms of medication. And then we just cantered through women's physical health in relation to hormones, the menstrual cycle, and the menopause. We're at wrap-up time, Lisa. What would you like to close out with? I can't believe we've covered so much in 55 minutes, to be quite honest.
No. I think a couple of things. One, there's quite a few questions about the pill and which pill's the best one. So anything that's high in estrogen is probably going to be better for you if you have that dodgy premenstrual week. Same with the HRT, the highest level of estrogen you can have. I just want to address one question that's been on there around younger children, and do we assess and diagnose younger children? Yes, we do. So if you want to get in touch with the office, if you want a bit more information, we can let you know why we assess younger children and help you with that. So yeah, please get in touch. But yeah, I've really enjoyed tonight. Again, we never have enough time. We always come to these things exhausted because we have such busy days and we're up early and we finish late. But then we always go, cracky, that hour's gone. Where's it gone? What about you, Phil? What do you want to end with?
I think I always take great heart from these, and no matter how tough the day is, these sessions always cheer me up. And having travelled back on a train from Manchester and literally walked in the house 10 minutes before we've done this, it's great to see the reaction that we have from patients and other people of the ADHD community. And there's a lot of questions coming at us from every direction in the chat and in the Q&A. We can't possibly address all of those things in this hour, but what it does do, and Kristen keeps an eye on them, is it helps us set the tone for the next webinar. And you know, we beg the NHS to put things into place with our NHS patients and contracts with the NHS that give them access to coaching, give them access to support. And in the absence of that, I'm really proud that we actually put these webinars on in our own time, free for people to start learning more and being better educated about their or their family's ADHD. And I'm proud of that. We will pick up on some of the subjects that have been asked for in future sessions, and Kristen will keep us honest to that. All I can ask of you is that when you get the social media hits from us, share them, don't just read them, share them, encourage other people to take part. This is an extremely well attended session, 112 people at its peak. It's really important that we get these messages out to as many people as possible, and sharing our social media posts is a really good way of doing that. We spoke for ADHD UK's conference 2 weeks ago, didn't we, Lisa? And we had 6,500 people on that, and we did one on ADHD medication and one on the treatment pathway. And if either of those are something that you'd like us to replicate, just let us know either in the chat now or whatever. But they're again important subjects, and there's plenty of important subjects in here to talk about. We're off to America twice this month with our own CPD and research to bring more back in terms of understanding the world of ADHD and understanding how we can do better. So keep watching, keep listening, keep using social media, support each other. Some lovely stuff going on here in the chat, and we'll see you next time. Kristen, thanks as always. Hugely influential session, and I think it's far too easy for Lisa and I to sort of talk about ourselves without mentioning you and the whole team at Disrupt who help us bring this all together. We might have outsourced our marketing, but we haven't outsourced it far. You're part of the family, and I'm very grateful for what you do. Someone's just said, the final comment I'll respond to, will you consider a webinar about parenting ADHD children when you have ADHD? Absolutely. And in the margins, I'd encourage you all to jump on Amazon and get the book and read the book, or go on YouTube and listen to the author of 1, 2, 3 Magic. You know, fill your boots with that stuff. But we'll do that, Kristen. We'll circle back around to parenting and parenting skills, and make that happen before the end of the year. And we'll do some more.